Okay, so this was a 10-month-old boy, history of IND over the right leg, classically drained by general surgeons, and then came to us as a gap non-union with loss of distal tibia. This is the kind of gap union that we had. There was a heel discharging sinus and a partial growth arrest at the distal tibial region also. So what would you do? Anyone? Shivam is closest to the mic, but someone else has volunteered. So next question goes to Shivam.
Tibialization of fibula.
Okay, you straight away want to jump to that. You don't want to investigate further. You want to plan any other problems that you see here.
No.
Any other options rather than tibialization of the fibula? Okay, so not a bad idea. The principles can be borrowed from that. But you still can use the same fibula in a little different way. You can use a non-vascularized fibula with nailing. You could do Elisa row and correct the deformity as well as do your grafting. You could do tibialization like you said, or you could have vascularized fibula, which are all, you don't want to burn out your options. You want to keep something for later. So this is what we chose. We chose the simple, straightforward, non-vascularized fibula grafting with a nailing, because there was going to be a mismatch in the diameter of the child's. He was a very young child, remember. So the graft itself is going to be thin. The tibial proximal metaphysis is flared, and the distal one is also flared. So we thought it best is first to just bridge the gap non-union using the ipsilateral fibula. And this went on to heal beautifully and even hypertrophy as much as your what tibialization would have done. Now what are we left with? Shivam? And how will you tackle that?
Shortening tibial, the limb length discrepancy will be mainly the issue, and also the tibia varus, which can be addressed by maybe Elisa row.
Okay. Do you see how well the donor fibula has hypertrophied and rather reconstituted? Anything else that you see in this X-ray?
we should keep him non-weight bearing.
Sure. So what we've done is we've used a double barrel sort of a fibula in addition to the plate over here. So what I want to tell you all is that this takes very, very long to incorporate. The femur, as compared to the tibia, doesn't heal up as fast. So you want a rigid fixation there. In addition, we put bone graft as well, and this took almost 12 weeks to really become have a good union. One end united, the other end even took still some more time, and then we kept him non-weight bearing for 3 months and partial weight bearing for 1 month, and then went on to walk. I think we'll do the last case and then wind up. How are we doing on time? 12 minutes. So then we perhaps may be able to get on to the acute sequence as well if necessary. So if you all remember something similar to Rohit's case, a 7-year-old girl, where again IND was done by the general surgeon, and 1 month later came to us with this kind of a picture. Almost the entire radius sequestrating off. This is the preoperative radiograph showing us how long the sequestrum is. Anyone, what would you want to do? Ankita?
So is there any active discharge?
Yeah, there was. So we waited till we cleared that, gave antibiotics, and we still have a situation there. So
you've got a long ulna. It's almost dislocated out. It is dislocated from the carpus. You've got there is a big sequestrum in the radius, so you would do a radial sequestrectomy. I might go for an ulnar shortening.
Right away, or you want
I'll wait for the. I'll do it as a staged procedure. I'll do the sequestrectomy, protect this arm. I still have a good length, so I might not put an implant right now. I'd just protect this kid in a slab, wait for the infection to completely settle down, and then think about reconstruction.
So precisely same lines of thinking. We wanted something to bridge or span in the meanwhile while we protect and treat the infection. So we did the sequestrectomy. We knew we had a large gap, and therefore we put a spanning fixator, which is what we were talking in Rohit's case. Very, very small fragment there. So we did an additional pin in the metacarpals there. So make sure that you maintain this length. Here the periosteum was completely destroyed. Otherwise, sometimes you find, to your surprise, some new bone starting to form when you add a rigid fixation there. So what next? Our plan was to do a stage fibula. I think since we've already discussed that part, I don't want to repeat it again. So again, huge donor segment that we needed over there. Time interval, these are just some principles which we'll quickly go over. Time interval between initial infection and surgical intervention should be ideally 3 to 6 months. 6 months is not always possible, but 3 months you can still achieve with a fixator. Then wet lesions we've already spoken about. You protect the donor limb in a AK cast, you refreshen the edges, take out any fluid or granulation tissue that is there on table at the non-union site. So you have to be prepared for ending up with a larger gap than what you have initially started with. So the donor segment you harvest a little extra always. Yeah, harvest it subperiosteally, 4 centimeters distal you leave behind, so that the ankle station remains stable and you don't end up with a secondary deformity there in the donor limb. And usually it's a very simple retrograde fixation with a long thick K-wire or a rush nail depending on the bone that you are dealing with. And forearm, always I think the fixator is a good device to have. That is how long a device it was. So in addition to the fixator, because I think the fixator had been on too long, we had converted it into a simple frame also for some time. We just put a simple K-wire and bent it, and a very simplistic frame. Took off the frame after some time and let the intramedullary device be there. And that went on to heal over about 12 weeks. And at the end of it, this is the picture that he had with a slight radioulnar variance. Now is where I would think of ulnar shortening. Graft consolidated well. We did that. We did the ulnar shortening, put in a plate, and also transfixed the radioulnar joint in addition. And that's the kind of lovely result that we could get at the end of, a whole lot of 1 year of the whole thing that has lasted the child.